Dear Professor and my dear students, I once again take this golden opportunity to invite respected professor and our students for another session of DNB academic activities by Railway Association of ISA on WebEx platform. Today we have some practical topics discussion like ward rounds. I invite Dr. Muthupriya to present the topic on preoperative assessment clinic. Over to professor and students.
Okay, I think this is the first time we are dealing with this particular practical exam platform of ward rounds. So far, for any of the batch, this has not been done. So to be honest, I don't know how exactly the examiners question the students on this aspect. So I have just made an attempt to share this information with you as routine ward rounds, which used to be or part of the stations examined in those days when ASCII was introduced for MD and DA in government setup exams. That time I happened to be the internal vigilant officer, so I just had an opportunity to observe how it is being conducted. So with that very small experience, I am trying to now conduct this. We'll just see how far it goes. I don't know whether I am doing it in the right way or not. But anyway, what you have to learn about this, from my experience, I am just formulated a few questions, and that is the way I think the question and answer session will go on in this ward rounds. Okay.
Okay, sir.
So, Muthupriya, whatever you have prepared, you first go ahead with that. Then I will, as usual, share my PPT with you. And there are a few question and answers in that. Let us see whether you cover that also before I go on with my presentation. Okay?
Okay, sir.
Right. Go ahead. What is the importance of a pre-anesthetic or pre-operative assessment clinic?
So it is routinely done for all the elective and emergency patient to assess the patient before they are fit for any anesthesia or surgery, sir.
Okay. Why should you do that? What are all the advantages of doing a pre-operative assessment?
Advantages, we can know about the patient's condition before proceeding for anesthesia and surgery, and to know the risk, post-operative risk, and about the patient condition, sir. Mainly about the patient condition.
What is the first and foremost thing you have to answer in the exam? If you are asked to say what is the purpose of pre-operative assessment, is it straight away to go and assess the patient's condition and then try to
know about the patient, sir?
First of all, you know, anesthesia was for a long time called as a behind the screen players. Anesthetists were called as behind the screen players. They call it in cine field. They are the behind the screens operative technicians. Like that, anesthesia was considered as second fiddle or a hidden specialty for a very, very long time, mainly because the patients got admitted under the care of the surgeons. And surgeons only told the patient what is the surgery they have to undergo for a particular surgical condition, what is the risk involved, how many days they have to stay in the hospital, and including what type of anesthesia will be administered. Everything was told by the surgeons, and they dominated the whole scenario. But gradually, the importance of anesthetists was recognized, and people started referring the patient to the anesthesiologist for opinion from them, so that the anesthesiologist will examine and then optimize the patient. So the first and foremost thing is now people with the internet and Google availability, they also learn about what is anesthesia, what type of anesthesia is administered for which type of surgery, So they are also becoming more knowledgeable, and they ask questions also. What will happen if you give spinal? Will I get a backache, or is there a chance some nervous problem will happen? Because some of my relatives or friends had an spinal cord injection, and then they said they had a burning sensation or weakness in the limb. So all these things they are aware of. They ask you questions on that. So the first advantage is you get to know the patient personally, and you develop a rapport with them so that they will be able to have a friendly relationship with you and cooperate with you. And then the second point only, you can explain to the patient what is going to be done in anesthesia, in surgery, and allay their anxiety and apprehension. Why should the anxiety be removed before the patient comes for surgery? What will happen if the patient is very nervous and anxious when they come to the operation theater straight away without seeing the anesthetist? They come to the, especially daycare procedure. If the surgeon tells them you come at 6 o'clock in the morning, the anesthetist will come and give you anesthesia, will operate, and you will be discharged by evening. In that case, if he is not seen the anesthetist who is going to give them anesthesia, what will be the nature of or mindset of the patient?
His sympathetic system will be active.
Very good. So they will have an anxiety which will stimulate the parasympathetic, the autonomic nervous system. So patient may have tachycardia and hypertension. In what way it is harmful? The patient is very anxious and having a stimulated sympathetic system.
If they're planning for any general anesthesia, it's an intubation stressor response. It will further aggravate his and like heart rate and BP.
Heart rate and BP.
Yes.
So,
ICP, sir.
pardon?
Central nervous system also, sir.
Central nervous system. What will happen to the central nervous system?
It will increase cerebral blood flow even during induction, sir.
Okay.
Intubation.
So, what way it is going to be problem for you?
It will increase ICP, so hot.
This ICP in a normal patient, just because the blood pressure goes up, will the ICP go up? They may require more anesthetic agents.
Yes.
Okay? So the system will be so much stimulated that a person who has been mentally tuned to undergo or know what is going to happen, he will require lesser doses of induction agent, lesser doses of analgesics. On the contrary, person who is very anxious and who is frightened, he will require more induction agent and analgesics to quell the same response. Okay, so that is the important thing that we gain by doing a preoperative assessment. And now you are in a big corporate hospital. How do you do your preoperative assessment? Do you have a separate preoperative assessment clinic, or do you go to each and every patient's bedside and then do the assessment?
For orthopedic cases, we have a separate room, sir, where we see like routine arthroscopy, TCAR patients.
Where patients are ambulant who can
And-
walk, there you have a.
Yes, sir.
But if a patient has a fracture, of course, he cannot be mobilized and you have to go to the bedside. And of course, special ward and paying patients, international patients, I think you are all asked to go to the patient's room and then do the assessment. Okay. So the assessment is done these two ways. One, it can have a separate assessment clinic or a outpatient block, or you can have a personal visit to the patient's room and bedside and do the assessment. So what is the advantage of having a separate clinic or a room for assessment, and what is the disadvantage of going to the room or bedside and doing the assessment? Do you think both are equal, or there is a difference between the two?
In pre-anesthetic room, there will be many patients. They will be waiting for a long time, and their blood investigations from the early morning. They will give the blood investigations, and by evening we see it, sir. So it takes a long time for them, sir.
Okay. That is
Hospitalized
the
patient mostly.
disadvantage for patient.
Yes,
I'm
sir.
asking from your point of view as the anesthesiologist in training,
Okay,
when
sir.
you are asked to attend the pre-operative assessment clinic on duty, which one do you prefer? You prefer to assess the patient in the anesthetic clinic, or you prefer to go to the room and then assess the patient at the bedside?
In a separate clinic, sir.
Why? What
It's
are the
easier.
advantages of assessing the patient in a specific place scheduled as pre-anesthetic assessment clinic?
We will have the diagnostic labs nearby, sir.
Lab,
So it
you
is
want all the investigations are ordered, and then the patients most of the time come to you with all the results, isn't it? Very rarely
sir.
you ask for extra results, I mean a test and to get the results. But there is always a package, surgery pack 1, surgery pack 2, depending upon the nature of surgery, and the surgeon orders that, and only after they get all the results, they are sent for your assessment, isn't it?
Yes, we
So
can
the
save.
lab, whether it is close or away, it is not a problem for you.
We can
We
get
can
a
save time and
opinion
energy,
right
sir.
away.
Hmm.
We can get super specialty opinion then and there, sir. It won't be
We
delayed.
can optimize the patient before prior.
No. My question is, you say you prefer to see the patient in the pre-anesthetic assessment clinic, whereas going to the patient's room or bedside and doing the assessment is little not advantageous. What is the difference? That is what I am asking.
Sir, we can save time and energy.
Save time and energy for whom? The patient or you?
Both, sir. So we can see more patients if we have a separate clinic. We can.
Okay.
Sir, if any problems, they will tell directly to us. If in any rooms, they can't tell.
Yeah. In a pre-anesthetic assessment, are you the only person sitting there, or you have a helping nurse, you have a counselor or somebody, and you have another colleague in case there are a lot of patients? Do you have some helping hand in
Yes,
an
sir.
assessment
Yes,
clinic,
sir.
or do you have a helping hand when you go to the bedside of the patient?
Bedside, we only.
Bedside, you are a single person. You go there and then you ask the ward nurse to come and help you. She may or may not know the routine. Whereas if you have a specified pre-anesthetic clinic and you have a nurse who is posted regularly, she will know the routine. She will always collect all the case sheets, sort out what are all the investigations needed, keep everything ready for you to quickly go through. Okay, and record the blood pressure and document it, take the height, weight, and calculate even the BMI and write it. So many things you will get a lot of help at the specified pre-anesthetic assessment clinic, and you will have a senior colleague or somebody to whom you can discuss and then ask any doubts if you have whether to give the assessment or not. Sir, the BP is so high, should we control it for more time and take up, or can I give the fitness now itself? So all those help we will get from the senior colleagues or the consultant who is there, which is not available at the bedside, number one. Number two, bedside patients are always more sick or not able to move or turn out in their position. So even to auscultate the back or examine the spine, you will require the help of a nurse, and patient may be put to some inconvenience because a fracture hit patient. You want to examine you would have seen when you go and examine the patient, to make them sit up and then examine the spine, it's a very arduous task for both you as well as the patient, because patient may be in pain and trying to shift him from lying position to sitting position and examine the back and see whether there is any bed sore or not. All these things are more cumbersome when you go to the bedside, isn't it? That is the disadvantage of doing a bedside assessment. But it is convenient for the patient because he need not be unnecessarily shifted in a trolley or a stretcher and then brought all the way from the ward to the assessment clinic and then taken back. That much of strain is not there for the patient. Okay, so this is the other thing. Now, what is the major advantage of, you said you will be able to know the patient's condition and then optimize. Which are all the special situations where such identification of the comorbidities and optimization is very much essential. Can you give a few examples?
If he has a respiratory infection, active
Okay.
LRTA,
Okay.
then
Is it so
cardiac.
common? Every patient coming for elective surgery, are you finding a respiratory infection in an adult patients? I can understand this point if you say the pediatric patient, but if it is an adult patient, how often you get a patient who is sent to you for fitness with a respiratory infection?
Few, sir.
Okay, so that is not the most commonest thing. So start with the common things.
Systemic disease like diabetes, hypertension.
Very good. That is the most very important thing. Most nowadays we find lot of patients with diabetes mellitus, hypertension, coronary artery disease, COPD. These are all the patients who are sent to you for preoperative assessment. So in that situation, what is the challenge for you to give the fitness? What are all the things you will look for in these patients, whether they are fit enough to undergo the planned surgery or not?
For diabetes, whether the sugar is well controlled or not, and whether he's on regular
Saying
medicines,
sugar like a
insulin
layman
or
person, what should you say? What medical term you should use?
diabetes.
Glycemic control.
Glycemic
Okay? That's a better terminology than saying like a common man, I will see whether the sugar or is under control or not. You must say the proper medical terminology in these things in the exam. So I will look for the glycemic control. Which important test is done to see the glycemic control?
HbA1c and
HbA1c. Okay, right. So if supposing the patient's sugars are not well controlled, the glycemic control is not satisfactory, what is the advice you will give
ask
for
him to
elective
get a
surgery and emergency surgery?
if it is elective surgery and if he's on any like insulin and regular oral hypoglycemic drugs, I will ask him to get a fitness like a specialist opinion before proceeding for the elective surgery, sir.
So you can ask the patient to go back to the diabetologist or physician who is treating the patient and make adjustments with his diabetic medications, and then see that the blood sugar. What is the ideal blood sugar value that you would like to have in a patient coming for elective procedure? What is the maximum? What is the minimum? We
Less
discussed
than 180
recently in
milligrams.
class.
Less than 180 milligrams per deciliter.
120 to 180 is the range. Okay, so that is what we want to achieve. And if it is within that range, we can accept the patient for surgery. Okay, and if the values are exceeding that, the patient comes with the value of 280, 300, then you ask the patient to get it controlled and bring it to less than 180 for any elective procedure, and then go ahead with the surgery. If it is an emergency nature like a cancer or an impending appendicitis, then you cannot wait for that long, and you have to make your own arrangements or use your knowledge on the management of diabetes and bring the blood sugar under control before you take up the surgery. Similarly, patients on coronary artery disease, if he has had a myocardial infarction 6 months ago, how do you like to assess that patient?
Like if it is less, like 6 months before he had a MI, that is a 6% chance of perioperative MI. So
Okay.
I'll ask him to do an routine ECG and echo.
Okay.
And look for any acute changes in that.
Okay.
If there is, and look for his like a functional capacity, like meds. If it is good, then I'll proceed with the surgery, sir. If it is poor, I'll ask for a cardiologic opinion and assess his stress cardiac status, sir.
Very good. What is the risk score you will utilize in these patients? If you have
revised cardiac risk index, RCRI.
RCRI. What are the components of RCRI?
If it is a major surgery, and if he is a diabetic requiring insulin, and if his creatinine is more than 1.2, and
you're not talking
if he
about
has
the
a
heart
recent
first
history of,
at all. You are talking about the diabetes and the kidney first. You say
Okay,
it is
sir.
a revised cardiac risk index, and the first
Yes, sir.
thing you should talk about is the cardiac status. and then
Okay, sir.
only go to diabetes. And because you remember those points first, don't say that in the exam. The examiner
Okay,
will
sir.
not like it. Okay, so first
Okay,
start
sir.
with the cardiac risk, then go to the diabetes and the renal system. What are the
Okay.
cardiac points that increase the risk?
Any history of myocardial infarction?
Infarction, congestive failure,
Okay, sir.
major surgery, paraginal
Stroke or CVA?
so a stroke for VNS, by diabetic requiring insulin, and cardiac renal failure with raised creatinine. Okay,
Yes,
so
sir.
this is the order in which you must say. You cannot
Okay,
jump
sir.
first, say about renal, diabetic, and then lastly you must not say the cardiac. So the presentation also is important in exam. So
Okay,
don't
sir.
first say the diabetes and renal. First say the cardiac point, factors which are involved in this risk index, and then go ahead with that. Okay, right. Then, if supposing the patient is on antiplatelets and anticoagulants, then how do you optimize those patients?
If he had a I look for whether what is the indication for his medications, whether he's on warfarin due to like wall replacement or like prophylactic anticoagulants. I look into it, and according to that, I will stop it, sir.
Very good.
If he's on antiplatelets like a prophylactic, I'll advise them to stop 5 to 7 days prior to surgery, like platelet clopidogrel. And if he's on warfarin for any valve replacement or due to major heart disease, I'll do a bridging therapy, sir, before stopping them, sir.
What about stents? Nowadays, the stenting is very, very common. Pulmonary stents.
Yes.
In that case, what will you do?
I look into the type of stent that they have done, sir, like whether it's a drug-eluting stent or a like bare metal stent. If it is a drug-eluting stent, if it is elective surgery, I'll post on the surgery at least 1 year, sir. And if it's a bare metal, at least 6 months, I'll postpone, sir. If
That
it's
is a
in
very
case
old,
of elective surgery.
old guideline that you are talking about. 1 year,
Yes,
6
sir.
months, and all. Now that is all gone now.
Okay.
Nowadays, the bare metal is only 3 months.
Okay, sir.
And the drug-eluting, you can even take up. I mean, bare metal is 6 months, and the drug-eluting is 3 months. You can, after 3 months, you can safely take up the patient, but you cannot abruptly stop the antiplatelet agents. You have to go for other anticoagulants which can be controlled, like heparin and fractionated heparin or low molecular weight heparin, and then bridge the gap and then take up the patient, finish the surgery, and go back to the oral antiplatelet agents they are taking. Okay, so these are the 3 conditions. And what is the other indication for patient coming with anticoagulants? Apart from valve replacement surgery or stenting or previous MI, is there any other condition in the cardiovascular system which warrants anticoagulant therapy? Any past history of cardiovascular disease, vascular disease?
Okay. Peripheral vascular disease.
Deep vein thrombosis. Okay,
Okay,
history
so
of deep
DVT.
vein thrombosis, patient may be on continuous anticoagulation. So those patients also require adjustment, especially which type of anesthesia is more dangerous in the presence of anticoagulation or antiplatelet agents.
Regional, sir.
Regional. Which regional? Single shot spinal
Spinal
or
anesthesia.
epidural? Spinal. Is subarachnoid block a very dangerous thing with anticoagulant?
Epidural.
Epidural, sir.
Epidural.
More of because why epidural is more riskier than single shot spinal?
Epidural, we use a larger needle, sir.
The chances of vascular injury is more because of the size of the needle. We use 16 and 18 gauge
18.
needles, and we use a blind technique, and we have to correctly identify the epidural space, which has got a lot of venous vasculature present in that. So the chances of injury to the vessel is more in epidural compared to using a 28 or 29 gauge spinal needle and giving a single shot spinal is much more safer compared to the epidural. Okay, so if you are planning for an epidural, you have to see whether the anticoagulant guidelines are strictly followed or not. Okay, so that is the another thing in this. And what other medical legal advantage is there in doing a pre-operative assessment? Nowadays, you find a lot of allegations against doctors saying that மயக்க டாக்டர் வந்து பார்க்கவே இல்லை ஒரு பாட்டுக்கு வந்தாரு ஓவர் டோஸ் ஆஃப் anesthesia was given, that is why patient did not wake up. All those blames you are all hearing and seeing in the papers. So what is the medical legal importance of pre-operative assessment? Are you writing your fitness in a particular page as a pre-operative assessment evaluation and fitness?
Yes, sir.
So that is an important part of the document of case sheet, isn't it? So it will speak for you in the court of law if you have done a proper pre-operative assessment and documented all the findings. For example, a patient with a known coronary artery disease who has suffered a myocardial infarction, if you have documented that this patient had a myocardial infarction 6 months ago, he comes under RCRI risk this particular number, then he has a higher risk for this particular surgery. And if you have got the informed consent and then you have got the signature of the patient with a witness, and if supposing intraoperative infarction or post-op infarction occurs and patient dies, you are very safe because you have already explained everything and you have documented and the patient knows about it, so nothing will happen. On the contrary, if nothing has been revealed to the patient and no documentation has been done, and on the table the patient develops a infarction and has some complication, then that may become a medical legal issue. Okay, so from that angle also you have to keep this in mind and document everything that you speak to the patient and tell the patient and get the patient's consent and signature with a witness so that you will not face any medical legal problem in the future. Okay, right. Now, with this small discussion, I will just go on to share the PPT. There are a lot of questions in that. Is it visible?
Yes, sir.
Okay. So what is a pre-anesthetic assessment clinic? What is the definition of that? How can you define that?
Assessment of the patient where thorough history taking and clinical examination is done.
So the exact the specialty clinic, okay, where patients are evaluated before surgery to establish a database upon which risk assessment and perioperative management decisions can be made. Okay, so pre-anesthetic assessment clinic or preoperative assessment clinic is a specialty clinic. It is not a routine OPD. It is a specialty clinic where patients are evaluated before surgery to establish a database. That is, you collect all the important details and store it. That is what is called the database, upon which the risk assessment and perioperative management decisions like pre-op optimization, intra-op drug usage and management plan of anesthesia, post-op requirements, that is the perioperative management. So you think of all the three, pre, intra and post-op periods, and take decisions and plan everything beforehand. So this is the full definition of a preoperative assessment clinic. It is a specialty clinic where patients are evaluated before surgery to establish a database upon the risk assessment and perioperative management decisions are made. This will include interview or talking with the patient, examination of the patient, a review of previous medical, surgical and anesthesia records, a detailed account of current medication use, and provisions for obtaining and reviewing preoperative testings. Okay, all these things are included. This helps to enhance the operating room efficiency and the quality of patient care. So this is the advantage of doing the preoperative assessment is it enhances the operating room efficiency and the quality of patient care. Now, what are the goals of the pre-anesthetic clinic? Already we have given it in a nutshell in the definition itself. What are all the features of the pre-anesthetic clinic? And the goals, can you just mention some of the goals? As you already said, we can know the
Reduce-
medical condition of the patient. We know what is the treatment he is taking, whether he is fit for surgery or not, anesthesia, whether any optimization is required. So we have talked about. So first and foremost, it creates a rapport with the patient and their families and allays their anxiety. This is the first point I told you. The second is it can reduce morbidity of the surgery by planning it, the amount of care, increases the quality of patient care, reduce surgical delays and case cancellations. Last minute cancellations are avoided by doing a proper preoperative assessment, and decreases the cost of preoperative care by telling the patient when will be the surgery and not asking him to come again and again and postpone. All these things are avoided so that the cost comes down. Provide a centralized site for pre-op evaluation to decrease the shuffling of patients to multiple service areas. Okay, so they can be seen in one location. Somebody said you can get a special opinion from the neighboring OPs which will be there in the nearby. I will tell you when it comes to the location and design of the pre-anesthetic clinic, and integrate and coordinate services through. Nowadays, after the COVID especially, the personal viewing of the patient or virtually seeing the patient is reducing. So we are doing what is called on-site facilities or online facilities for improving the patient, getting all the details that they want, and then ask the patient come for admission straight away, and doing all the required insurance authorization, lab testing, everything can be done by online counseling. And provide anesthesia medical consultation for evaluation of medically complex inpatients and outpatients. That is the major part of this. And develop protocols, policies, and clinical pathways, and you can give a good quality assurance for this patient. And lastly, maximize efficiency in operating room function and turnover time by coordinating all three of information in one location, and a good liaison between the Department of Anesthesia, Surgery, Nursing, and hospital administration. Okay, so this is an important thing that is happening. Now, the question is how to design and locate pre-op assessment clinic. So this question has been asked in the theory examination also. Sometime back in, I think, 2022, there was a question of pre-operative or pre-anesthetic assessment clinic, was a theory question. So both in ward rounds as well as in theory, this will be useful. So how to design and locate this clinic? It should be easily accessible from main entrance of the hospital. So patients should not be asked to roam around and find out where it is. Preferably in the main outpatient department block itself, near surgical specialty clinics. That is the location should be, and it should be preferably on the ground floor, especially for geriatric cases. And there should be an easy access to hospital diagnostic and other support facilities for and there should be enough drinking water, toilets for patients and their relatives should be located in that. And the physical design of clinic should provide adequate space demarcated into areas for registration and reception, patient interview and examination, patient family preoperative education area, staff rest area. There should be a snack and coffee shop in case patients are waiting, diabetic patients who may feel hypoglycemic for them. They should have a facility for having something to eat, and separate washrooms for patient and staff. And what activities and conditions to be provided in the pre-anesthetic clinic? Evaluation through review of medical records, history examination, and relevant ancillary testing, and mainly risk optimization. This is the main purpose of this particular clinic. Then we can discuss the risks and benefits of anesthesia options and pain management strategies with the patient, and alleviation of anxiety through counseling, patient and family education on topics such as Fasting, how many hours of fasting? Patients may have a lot of questions. Sir, he is a diabetic. Is it advisable to fast for 6 hours? Or can we give something if he feels hypoglycemic? And all those questions we can clarify with them and then give them a good guidance. Medications to continue, like antihypertensives or anti-anginal drugs or diabetic oral drugs, which one to continue, which one to stop, and any special nursing care requirements. Then on anticipated duration of hospital stay, transportation issues, all these things can be discussed with the patient. And validation of consent and documentation of advanced medical directives. And that is also part of the preoperative assessment. And reduction of day of surgery delay and no show via telephone calls made on the day of surgery. So you must get the contact details of the patient so that you can call them and remind them about the surgery, especially when they are asked to come as a daycare on the day of surgery. You can remind them that tomorrow such and such time is your surgery. You are expected to be in the hospital by 7 o'clock and you should come on empty stomach. You can give a reminder about fasting and all those things. So the contact details is very, very important. That also should be taken in the pre-assessment. Now, who should be the staff in the clinic? Normally, in your you said you have a separate pre-assessment clinic for the orthopedic patients who are ambulant and coming for pre-ass. So, how many staff you have in that clinic? Do you have any consultant ranking assistants in that patient, or only the postgraduates are there?
Sir, if the patient is need a further assessment, means we will call the consultant.
Regularly, how many of you attend the pre-anesthetic clinic? That's the question I'm asking.
So one doctor and 2 staff nurses.
One doctor. And the doctor's eligibility is a postgraduate or is he an assistant or consultant of junior consultant, senior consultant, registrar, which grade?
Postgraduates.
Postgraduate. So mainly postgraduates are taking the assessment, and any doubts you will call the consultant, isn't it?
Yes, sir.
And ask them to clarify that. So yes, but strictly speaking, a senior specialist or consultant should be responsible for the policy administration and quality of this. And there are several model staffing in the pre-anesthetic clinic. It may be the anesthetist or the anesthesia trainee or anesthesia nurses. So in the Western countries, there are nurse anesthetists who are qualified, trained in anesthesia. So they are asked to do the pre-anesthetic assessment. And only complicated cases they will bring to the consultant consultation and get their opinion and record it and document it. Otherwise, mostly, as you said, the junior most persons are the ones who do the assessment, and they are of course given training as to how to do the assessment. What are all the systems you should examine, and what are all the abnormalities if they are present. You should bring it to the notice of the consultant and get the clarification. All that is being taught and trained in that. And who should be the patient? When should the patient be assessed before surgery? What is the time duration in your hospital? What is the policy you follow? For example, an elective arthroscopy, supposing patient wants it, say, after 2 weeks, and you see him today, is the fitness holding good after 2 weeks also?
Most of the patient, yes, sir.
Yes. So depending upon that, there are patients may be assessed from 2 to 30 days before the scheduled date of surgery. So until that time, the fitness will be valid. And what is the method of obtaining the information needed from the patient?
History taking.
This is specially designed questionnaire. You can have a printed type of questionnaire which you can give to the patient or the attender, and then ask them to fill up this specially designed questionnaire. And this can be, of course, distributed in the waiting area and ask the patient to fill up with the relatives. And there is a algorithm which is described for preoperative evaluation. One is assess surgical risk based on the nature of surgery, which is classified as mild, moderate, and high risk surgery. The second is assess the functional status of the patient and see whether he is fit enough for this particular type of surgery. Third is assess the stability of the patient, whether he has any shortness of breath, history of syncope, chest pain, leg swelling, or the nocturnal dyspnea. All these things should be giving an indication of the cardiovascular status and the patient's respiratory system also to some extent. And if he needs a specialist opinion, this is based on this 1, 2, 3, then you can do that also. Now, the benefits of an effective pre-anesthetic clinic are reduction in excessive preoperative testing. So, but corporate hospitals, they have a package. So whether it is needed or not, we will do all that and fill up the coffers. And reduction in subspecialty consults. So patients, I mean, especially the anesthesiologists, I used to tell them we are the physicians for the surgeons. So we are the ones who have to take a decision and unnecessarily referring the patient to cardiologist, nephrologist, gastroenterologist, neurologist. We should have a overall bird's eye view of all the things to make an assessment whether we can take up the patient safely or not. So having a PhD staffed by physicians who are trained in both internal medicine and anesthesia enhances the quality of patient care and hospital of the cost of savings. And enhanced operating room functioning will happen. So how is pre-anesthesia evaluation done for daycare surgery? Is it different for inpatient from inpatient assessment?
It is same, sir.
Same, okay. There are some subtle differences. Outpatient anesthesia assessment needs to keep pace with the increase in number and complexity of the ambulatory surgery population. That is number one. Two, patient screening done 1 to 30 days before or admitted on the day of scheduled surgery. So in between, if anything happens, you must instruct the patient to inform the department or the surgeon about the changes that are taking place, because you are going to see them after 28 days or 30 days on the day of surgery. So anything could have happened in between. So even though the validity of the assessment is there, if there are anything that is happening in notable incidences or change in the patient's physical condition or medical problems or issues, it should be immediately informed to the anesthetist and surgeon so that we can modify our assessment and again recheck the validity of that assessment. And outpatients posted for day surgeries are now routinely screened pre-operatively using several methods. What are the methods? You can use questionnaires, you can use telephonic interviews, you can even use Skype or Zoom or your Google Meet and see the patient and evaluate the pre-anesthesia, or they can physically come to the pre-anesthesia assessment clinic and get the assessment. So the options are more compared to the inpatient assessment. And the pre-anesthesia clinics and telemedicine technology is also becoming more now. The patient does not have to travel for routine consultation. If an expert consultation is required in case of comorbid condition, even that can be arranged by what is called teleconferencing in the presence of the anesthetist. So all three of you can go into con call and then describe the problems and get the solution from the specialty people. And the most limiting factors for implementation of a functioning pre-anesthetic setup is lack of finance and shortage of anesthetists to run the clinic. This is the hardship that we face in many of the situations. And now there is an article in the Indian Journal of Anesthesia where the ISA top people have formed a group to assess, give a guideline as to how long the pre-anesthetic clinic validity assessment fitness is valid. Even though routinely I told it is about 30 days, they have given the guidelines for the various things. So as part of the guidelines by ISA, blood investigations which are done are valid for 2 months provided there has been no change in the patient's condition. That is about the, so you need not unnecessarily ask them to go and again have a CBC, RFT, LFT, all these things. So if you assess them with the results 2 months prior, unless patient says I had a urinary infection, I had a jaundice, I had a fever, I had a sore throat, no need to repeat the blood investigations up to 2 months. Then with regard to X-ray test, ECG, echo, it is valid for 12 months provided there is no change or medical issues in between. And the patient fitness is valid only for 1 month subject to there being no change in patient's condition. This is given in an article in IJA where about a dozen senior ISA members have formed a group called the core committee, and they have decided on the time interval as a guideline to follow, which is being published in the IJA. You can go through that article. And how to sort out the issues of assessment, anesthetist being different from OT and the assessment unit. You can sometimes you would have all come across the assessment clinic anesthetist gives fitness, especially in pediatric patients. He says the child is fit for, say, for you being in orthopedic hospital, the child is given fitness for clubfoot correction. Then it is done as an outpatient, and child is asked to come after 1 week, giving the appointment for surgery. On the morning of surgery, when the child arrives, it has a running nose. Then the theatre anesthetist may say, child is not fit, I cannot take up the child because it has a URI, it is more risky, so you may cancel the case. Or you do assessment in the assessment clinic for a patient with coronary artery disease and hypertension. You feel that patient is under good control with all the medications, but on the day of surgery, patient has some mild chest pain or discomfort, and the OT anesthetist feels he is not fit for surgery on that day. So this sort of confusion may happen at times. So how to manage that situation? Have you ever come across any such problem?
Yes, sir.
So in that situation, how to manage that?
So the OT anesthetist call should be the main thing, sir.
Main thing, because
Yes.
he is the one who is going to be there.
Yes, sir.
But if supposing, can this be sorted out even before it arises?
Yes, sir. Before, by regular phone calls, he could.
Communication. So
Yes,
the
sir.
good communication and liaison is very important if the PAC anesthetist and OT anesthetist are different. Okay. So whenever you give fitness for a high-risk patient with morbidity, comorbidities, it is the duty of the pre-anesthetic assessment clinic anesthetist who gives the fitness to call the OT anesthetist, whoever is going to anesthetize this patient, and describe what are all his findings and what are all the risks that the patient has, and why he has given the fitness, and in what way it will be helpful to the OT anesthetist. If he already knows that the patient is already having a stent in place, he is on antiplatelet, he has been asked to stop the antiplatelets, and he has been converted or switched to heparin. If all this information is available to the OT anesthetist, in what way it is going to be helpful?
He can anticipate the risk.
Risk and prepare himself, equip himself.
Yes, sir.
Okay? The PAC anesthetist should inform the issues in care witness has been given to the the concerned anesthetist. For example, anticipated difficult airway, morbid obesity, patient on anticoagulation, etc., will help the OT anesthetist to equip themselves to manage such patients safely. Okay, so this is the very, very important point to prevent the confusion of cases getting cancelled because one anesthetist gives the fitness, the other fellow feels he is not fit, and Patient will be the ultimate sufferer because he will unnecessarily get postponed from surgery. And why pre-anesthetic assessment is more challenging in pediatric patients compared to regular adult patients. These are all some lateral thinking questions which are not in the books. I thought this is from my practical experience. I thought I will include these questions. History taking depends on the ability of the parent or the caregiver to correctly provide information. Because you normally don't ask a 3-year-old child, do you have a cough, do you have a fever, are you eaten full stomach? We don't ask the child directly. So it is the
Yes, sir.
caregiver or the patient from whom we get the history. So we have to be very careful in taking the history. And stranger anxiety will make older children anxious and uncooperative, leading to difficulty in examination. Especially when they see the stethoscope, and you go near the patient, they start crying and yelling. That will make them have a runny nose, and that will make them cough. And you auscultate, you feel as though there are some clefts which are not actually present. So all these things will make the examination difficult. Children are more prone to develop URI anytime, and despite being given fitness, if such condition happens on the day of surgery, it will lead to dilemma as to postpone or the surgery or to go ahead. This is a very common scenario that all of us would have come across at one time or other in our practice. Now, how do pre-op assessment in patients who are not ambulant? How is it done? What is the drawback? Of course, this I told you in the beginning itself, that assessment in patients who are not ambulant has to be done at the bedside. A thorough examination may be difficult in these patients, as turning them for auscultation or examination of the spine may be difficult and inconvenient to the patient. Okay? So this is the questions that we thought will be useful for this topic, pre-anesthetic assessment clinic.